All right. Welcome to another episode of the Black Surgeon Podcast. My name is Dr. Wibonele, and today we're going to be doing this general surgery match panel. I'm super excited to have these two amazing new surgeons. I have Dr. Olivera and Dr. Granville. I'm sorry, Watkins-Granville, right? Is that how I pronounce your name?
Yes.
Perfect. So, guys, why don't you introduce yourself? Tell me a little bit about where you are going to medical school and where you matched to. We can start with Dr. Olivera.
My name is Justin Olivera, very recently Dr. Olivera, born and raised in Jersey. My mom is an educator, my dad is actually a surgeon, and so that was my first exposure to medicine and to surgery. And so like very early, it made a strong impression on me having a black man in surgery as my role model. He's a urogynecologist, so he did OB-GYN and then urogyn fellowship. I ended up going to undergrad at NYU. I studied public health and biology, did medical school at Einstein, took a year off in between to go down to the NIH to do research. And I matched to Massachusetts General Hospital for general surgery, and I'll be starting next week.
Yay.
Nice.
Awesome.
Congrats.
Thank you. Thank you.
Naomi.
Yeah, I'm Naomi Watkins-Granville. Most people call me Nay, so if anybody reaches out to me after this podcast, just call me Nay. It's fine. But I'm originally from New Jersey as well. I went to Rutgers, New Brunswick for undergrad. I took 4 gap years in between undergrad and medical school. I got a master's at NYU. So Justin and I have some commonalities here. I got a master's degree in biology and I worked as a clinical care technician for about 2 years. And then I went to Rowan Virtual School of Osteopathic Medicine for my DO degree. Recently graduated and I matched at Temple University Hospital for general surgery. So I'll be in Philly. And yeah, I am a first generation physician. So I don't have any physicians in my family, but my grandmother was a registered nurse, kind of during a period of like severe discrimination against, Black women healthcare professionals. So she had to climb a lot of mountains to, get her to become a registered nurse and to help people in the way that she did. So that kind of spirit of healthcare and helping people lives somewhere in here. And so I think that's despite not having necessarily the blueprint, I did have that spirit passed along to me.
Nice. That's amazing. So tell me a little bit about what made you decide actually to go to general surgery and what influenced that decision. Maybe we can start with Dr. Watkins.
Yeah, so I actually have a very interesting story which impacted a lot of the ways that I mentor minorities to go into surgery. So while I was a clinical care technician, then I was an ambulatory technician. I transferred some of my skills in phlebotomy and EKG tech into a pre-admission department. It was just like kind of a different job when I moved. And so pre-admission, as you guys know, some patients need medical clearance. So I would do their phlebotomy and do their EKGs to make sure that they were optimized for surgery. And two separate departments. Pre-admissions on the first floor, OR is on the second floor. We never interacted. Like whatever they had going on up there, they interacted through a mail chute, essentially. Any lab result would get shot up into the OR and no one talked. It was like talk through the phone,
Wow.
all that. So I was totally unfamiliar with surgery, even though proximity is super close. But one day my boss, she comes downstairs from the OR and she's like, Naomi, I need you upstairs in the OR. Kathy, she's a administrator who had been there for 20 years. She was sick and she needed to leave like immediately and they needed coverage upstairs. And I'm like, the youngest person in my department, I guess she thought I could catch on quickly. And I was like, okay, I'll go up there. And I really believe that surgery is one of the most like not it's like one of the most unknown fields if you're not don't have exposure to it. Like it feels scary, it's highly dramatized on television. And so even if you're interested in medicine, it's just a field that you never thought that you could be interested in. So as somebody who I'm like, I think I might be like 22, 23 at this point. I only know Grey's Anatomy. I go upstairs, they're like, don't pass this line. You need these scrubs, this hat, this mask, this. And I'm like, all right, I'm into something new here. But to make a long story short, I was the new person around, and all of the surgeons, they're looking to get stuff done. They're looking to get it done quickly. Kathy used to pull all the strings, and it's just little old me at the desk now. And they want to, get to know me. They want to know how we can interact, how we can talk, and I can help them get things done how they want to. So after getting to know them a lot better, they wanted to get to know me, and I told them that I applied to medical school, and they let me into their ORs. So on
Nice.
my breaks, on my, days off sometimes after work, I would see pretty much any surgery I wanted to see. They had urology, ortho, general surgery, GYN, pretty much everything in that OR. And so for me, I was like, it's like a feeling when you catch that surgery bug. You're like,
Mm,
I don't know what I'm feeling right now, but this is for me. And you kind of just know. But the overall feeling of like just the surgeons being so like dexterous, being able to like make a move so quickly, being able to adapt to mistakes fast, and the immediate feeling of being able to help and treat your patient, that was something that stuck to me extremely quickly. And I understood the privilege of being exposed to surgery from like on accident, right? But I'm like, what
mm,
about students who intentionally get exposure, right? Like
mm,
prior to medical school. So I started a program at my school where we brought undergrads to our school to learn about the different surgical specialties, pathways to surgery. We showed them surgeries on YouTube and suture workshops, helped them meet residents and stuff like that. So long story, but I stumbled across it, fell in love, and yeah, just huge opportunity for advocacy in that space as well. Like we know that there's a literal and figurative cost to surgery, especially for minorities. So that's an opportunity. Uh, there needs to be more of us in the space.
nice. Nice.
Sorry if that.
I love. No, that was great. That was great. It's such an amazing story. I
Oh,
just
thank
found
you.
out stumbling into it, and it just shows. It shows the passion that you have for it. And kind of why you're doing this whole thing. So I appreciate that.
Thank you.
Justin, what about you? How did you
Yeah.
find general surgery?
Yeah, so as I mentioned in the intro, I think my very first exposure to medicine and to surgery was through my dad. And like one of the earliest memories I have is so he kind of did things a little bit backwards. I think most people traditionally will finish residency and then go straight to fellowship and then practice. He finished residency in OB-GYN and then practiced as a he had a private practice and was operating at a community hospital. Then he went back and did fellowship. And I remember when he was practicing as a private physician, walking around in the community, and this is like Plainfield, New Jersey, which is a low income area, majority Black area. And just like I remember like patients would stop him on the street and be like, "Oh, Dr. Olivera, like you made my life so much better." At this point, he was doing obstetrics mainly. Like, you made my life so much better. You delivered this my child. Look at these pictures, and that made a really strong impression as being just a little kid. And at this point, I didn't know anything about medicine or about surgery, but I just knew that like people in the community had so much respect for my dad because of what he was able to do for them, and that made a really strong impression. And then I also remember like kind of around the time that he was about to go back and do fellowship, he was really excited about the robot. Urogynecology was one of the first fields to adopt the robot. And so I remember like sitting at the dinner table, he'd be like passing around his phone and showing these like really low res pictures from the robot console of like robotic surgery. And I had no idea what I was looking at. Everything was just pink and red, but it was just like so cool. It was like science fiction. And so that was like my very first exposure. And from that point, like I knew I wanted to do medicine. I would tell people that I wanted to do surgery. I didn't really have a good reason for it. Something that was really profound and impactful that happened when I was in high school was my grandma actually got diagnosed with stage 4 cancer. And so she started having these symptoms. She went to the doctor late, which I think in and of itself speaks to health disparities, and especially among Black women, which I'll get back to later, and ended up getting diagnosed with stage 4 ovarian cancer. And so even though it was non-operative, seeing the importance of the hospice team and how much they took care of her and how much she appreciated that in her final days made a really strong impression on me. And so at that point, I was interested in surgery and now became interested in surgical oncology and what it could look like to be on the opposite side of things, being involved in early detection and addressing health disparities. And so I think that goes into what I studied in undergrad. I studied public health and biology at NYU. And that really gave me a language for health disparities and understanding why the things that I was seeing in my community, in my family, that was so normal for us was not normal and was actually like in a lot of ways by design. And it results of hundreds of years of institutional things. And so then I became really interested in medicine from a public health lens. And kind of in a roundabout way, I got introduced to thoracic surgery. And so my earliest mentor in general surgery and thoracic surgery was actually Dr. Raja Flores, who's the chair of thoracic surgery at Sinai. And a really roundabout way, I ended up in his OR and was shadowing him. He showed me that, like, he introduced me to the team, had me in the OR. I was a college student at this point, getting up at like 4 o'clock in the morning to take the train from NYU up to Sinai. And I remember, like, the very first case I saw, I was like, this is what I need to be doing. It was I think it was like a thoracotomy and a pleurectomy, and so like they crack the chest open, they're separating the ribs. It's a huge case. You're looking inside the rib cage. You're watching the heartbeat. You're watching the lung deflate and inflate. And I was like, this is the coolest thing ever. And so that was kind of the beginning of it. And then so I got to medical school with this interest in general surgery, interest in thoracic surgery. Linked up really early with the thoracic division there. And then, Dr. Brendan Stiles, who's the chief there, has been another instrumental mentor for me. And I think it gets to this thread of like very major mentors that were invested from a very early point in my success and really embracing me and like showing me that it was possible. We know general surgery and then specifically cardiothoracic surgery, like there are no Black people. There are, obviously, but it's a very, very small percentage. And so having mentors and sponsors, Dr. Roger Flores, Dr. Andrea Wolf, Dr. Brendan Stiles, those were kind of the earliest people that embraced me, showed me that this was possible, and then cultivated me, even as an early junior medical student, showed me research, got me in the OR. And so that was like my very first exposure to really what it meant to be a surgeon scientist. And so I stuck with that interest and like saw a bunch of stuff through general surgery. I saw almost everything that you can do in terms of like subspecialties, and was still set on like thoracic surgery is I think the coolest. And I think for me, it marries a lot of the really technical operations, delicate dissections. You're dissecting around major vasculature in the chest. You're operating on the heart. You're operating on the lungs. But then on the thoracic oncology side, there's a ton of research that's really exciting around novel therapeutics, immunotherapy, targeted therapy, making sure patients with cancer are living better, longer lives. But for me, from the public health angle, making sure that everybody's getting access to these. So especially racial ethnic minorities, especially low income patients, making sure that they're getting the same opportunities. And so that's what I'm really excited to do in my career.
Nice. That's amazing. Also, really sorry to hear about your grandmother that she,
Thank
the
you.
detection was
Thank you.
pretty
Thank you.
late. That
Thank you.
a lot of people have that story,
Yes.
Unfortunately.
Yep.
Yeah. So tell me a little bit about, the application process for people who will be applying this next circle. How does one become a good and competitive general surgery applicant? I'll start with you, Justin.
Yeah, I think there's a couple things that you need to decide really early on, kind of similar to when you're applying to medical school. I think it's all about, I remember Dr. Spain, David Spain, he's the program director at Stanford, and he gave a talk at the Society for Black Academic Surgeons when I was getting ready to apply in September. And he said something along the lines of, there's no perfect program, but there's a perfect program for you. And the best program for you is the program that you end up at. So I think this is really one of the first opportunities in your career as a medical student to decide what type of program you want to be at. So I think very early on, decide, do you want to be at a community program or do you want to be at an academic program or some hybrid of the two? And that kind of gets you started on like generally what type of programs that you're looking to be involved in. If you have an idea of a fellowship interest that you have, you should make sure that, especially if it's a competitive subspecialty, that program has a really strong track record of sending people into that. And B, that it has like my program director now, Dr. John Greer, he always makes a point of saying like a really healthy program is one that's sending people into everything. And so if it's a program that's only sending people into MIS or only thoracic or only one thing, then that's probably not a good program to be at, because if you decide you want to do something else, there might not be the support for you there. If you want to do pediatrics or you want to do cardiac and that program has never sent someone there in the last 10 years, that's probably not a program for you also. And then aligning it with your own interests. If you're really interested in research, making sure that it has a really robust research infrastructure. If you want to be really involved in academics as a fellow and as a junior faculty member, if the program gives you no support to do research, that's probably not the place for you, even though it's an academic program. So those are like the really high level things. And then I think something that's also really important that doesn't get talked about enough is the experience of underrepresented minorities there. I mean, I'm assuming we're talking to the audience for this is people of color. Even if you're not Black, people of color, it's a unique experience being a medical student, being a resident, being an attending as a person of color in surgery. And so you need to make sure that that program has a track record of really being intentional about supporting you. If you're the only one, if you are coming into the program as the only one ever that they've had, kudos to you, but that also means that they don't know how to deal with you. They don't know the unique things that you need to feel supported. And so it was really important for me as I was going through like that really early recruitment season, like, July, August, September, even before applications were sent out, going to open houses, seeing, do the residents take time out of their free time? Do the Black and brown residents, when they have time off, are they going to the open houses? Are they excited to talk about their program? Are they genuinely happy? Do people kind of like, does their hair kind of go on, like stand up on end when the program director walks into the room? And do they get nervous when they're like talking in front of attendings? All those little things, those body language things, it tells you what it's like to be a person of color there. Um, yeah, I think there's more, but I'll stop talking.
No,
Oh,
that was
those are
really good.
those are great.
Yeah, that was all really good. And I just want to echo, yeah, I wanted to echo the first point as well. Like, as early as you can decide, right? Like, even if you're not sure, positioning yourself to have a strong surgical application will help you, even if like it's like fourth quarter, you're like, actually, no, or actually, yes. You're not scrambling for certain things, to get ready. And, just from like a DO perspective, if you want to, at this point in time, it's not necessarily fair, it's not necessarily right, but you have to take DO and MD boards. It's not a requirement. Obviously, by law, they cannot say in order to match general surgery, you have to take DO and MD boards, but this is the climate that we're in right now. There are certain specialties where it is 100% not required. You can successfully match at any program that you want to without it. But at this point in time, you definitely should. And so as a DO, you have to decide from step one, which is the end of your second year of medical school. If you even have a thought that you want to apply to general surgery, you should sit for step one. And that kind of brings me to my next point, is to perform as well as you can academically. Because the people that are applying to surgery are going to be the people, I mean, not everybody has the best grades, but particularly as a DO candidate, you have to measure up to your MD counterparts. So making sure there's not a blip in your application that can kind of put you in a position to be overlooked, right? So making sure that you perform well academically in your preclinical courses and doing as best as you possibly can for your board exams. And then also, like, if you choose early, right, getting research experiences and things like that are also super important, but having surgical experiences. So, for example, when you apply to residency, they're going to ask you, how do you even know that you want to go into surgery, right? And a lot of people had sub-Is, they had electives or things like that, but how did you even decide in the first place? So your first and second year can be filled with these small shadowing experiences of different surgical specialties. You have a mentor. Justin mentioned his mentors in thoracic surgery. I am interested in breast surgical oncology. So I have a breast surgeon mentor, right? She's more of like a sponsor and an advocate for me and things like that. And so I kind of know what the day-to-day life, what the bread and butter procedures, what the most common treated disorders are in the specialty that I'm interested in. And so I can add that to my repertoire of saying, this is why I want to be in this field. This is why I want to pursue this specialty because of my experiences. And so yeah, like those different things matter a lot. And yeah, just essentially having a well-rounded application is important too. There's a bunch more details, but I think like between Justin and I's responses, I hope that can help someone who's just starting off in medical school try to decide where they might fall, in that perspective.
I also realized I completely answered the wrong question. I thought the question was, how do you identify programs? I'm sorry. Real quick, I think things that make you super competitive. I agree with everything Dr. Watkins said. I think the one thing that I would add is that especially recently, step one is now pass fail. Most medical schools are completely pass fail. And so I think personal communication matters more than it ever has in the general surgery cycle. What I mean is not you communicating with programs, but having mentors and sponsors that are reaching out to your behalf, on your behalf, to programs and saying, you should really take a look at this candidate. I've known them for a while. I think they'd be really good for your program. And so I think to get to that point, you have to cultivate that relationship as a first and second year so that they get a chance to know you and see how you work and how you handle things and how you take on projects. And I think one other thing is that if you have an inkling that you want to be at an academic program, you need to start developing a narrative that people will read and say, oh, okay, that tracks. And so if you say that you want to get to residency and be involved in cancer research and be involved in all these things, you should have that on your CV already. So I think what makes it really compelling is when people say, all right, Justin's going to do all these things as a resident because he started to do these things as a medical student. We can be here as a resource to support him to get him to a higher level. And that's academically, and they want to see that they can take you and make you nurture your growth to get you to that next level.
I want to echo that point as well. Your application should tell a story, right? It should tell a story about who you are, what you're interested in, and then what you're going to continue to do in residency. And so, exactly like Justin said, I also have an interest in surgical oncology, particularly breast, maybe other parts of surgical oncology. But the fact that you can speak to, I worked with this person, I have this type of research, I shadowed this, put together this type of program, and in residency, I will continue to do blank, blank, blank. That program is like, absolutely, we can support this person in exactly what they want to do. Like, I, looking back on where I matched, it made perfect sense based on my application, right? Like, I talked about the research that I want to do. I matched at an academic
Yep.
institution, but I talked about
Yep.
the healthcare disparities and the different things that I experienced as a Black woman and my family experienced. And I want to help a certain population. I matched in Philadelphia. So, like, everything kind of just does come together if you put yourself out there and present yourself as the type of person that will fit their program. Yeah.
Nice. That is such a good advice. I really like the point of you guys saying, you know, make a story out of your story essentially, because people want to know where you came from. People want to know where you are today and where you're going, right? And then based on that story, they're going to look at their program and be like, I think this person is going to fit perfectly to where we are, and it's going to help. We're going to help that person as well to go to where they need to go. So I don't think we can say that any better. You guys kind of aced that one amazingly. I wanted to touch a little bit about step one and step two. When I was coming about, we had all those. We had to take step one, step two. There was no pass fail. My medical school was not pass fail, so we had to have all the grades. I know step two is still not pass fail, right now,
It's
or
a
is it pass
board.
It's
fail?
not.
Yeah, it's not. So tell us a little bit what you think, the pass fail part of step one, and should you take step two before you apply for residency, and how important is that, and how much do they look into it? Naomi, you can start with that one.
Yeah, I will say for general surgery residency, I really try to not be that like person to say that that score is everything, but I do believe that it positions you to get interviews. Just, Austin, you could correct me if I'm wrong, but the overall consensus of what I've heard is that that is a filter, quote unquote,
I agree 100%.
for residency programs. I think what the two most common filters that I've heard are first time step one pass and then also your step two score. And it puts a lot of pressure on your step two score because that's the only number that they have, especially if you come from a pass fail medical school. But it's extremely important, I think, to take it prior to your residency application process and to score well, at least to get an interview. And once you get your interviews lined up, the rest of your application kind of takes it all the way. And then that's where you do see the benefits of a pass fail step one. Like, you kind of have a more well-rounded application now because you know that that step one score in your first 2 years was not the determining factor of you going into a certain specialty. So you could do more volunteering, you could do more research, you could do, more extracurricular activities. But then that step two score gets you that interview for them to even review the rest, right? So
Yeah.
Yeah, Justin, you can correct me if I'm wrong or if you have any other opinion.
No,
Yeah,
no, I agree 100%. Real quick, I just want to ask, is my video frozen for you guys? You can see my video.
it's frozen.
It's
For me at least.
it's frozen.
All right, I'm just gonna turn it off. I don't know how to get it unfrozen. I'm sorry.
No, you're good.
But no, I agree 100%. I think that step one, being pass fail, means, like Dr. Watkins said, you need to pass it on the first try. You have flexibility now to, you don't need to get in the top 1 percentile like you needed to 10 years ago to be as competitive, but you do need to pass on the first try. And so what I tell my mentees now is get to a point when you're about to take it that you're comfortably passing, and that margin is different depending on who you talk to. But if a 60% correct overall is a pass, I advise people to get between a 65 or even above a 70 before you go in to take that test so that you can comfortably pass. It is not the end of the world if you don't pass. I know I have friends that this past year that have matched into highly competitive surgical subspecialties without passing on the first try, but it is a major question mark on your application and a red flag now that people are going to want you to address. As far as step two goes, I agree with what Dr. Watkins said. I think it doesn't need to be the highest score for general surgery. It's not orthopedic surgery where you need a 260 or a 2 match to a really strong program, but it can't be prohibitively low. I will say I did not do very well in step two. I still ended up at the program that I wanted to go to, but I didn't interview at a couple places that I really wanted to because, and I think that that's because of my step two score. So it doesn't need to be super high, but it also can't be prohibitively low. And just to give people a number to shoot for, I think 240 or even 245 is what a lot of people are saying is their minimum cutoff now. I got a 236 and I still interviewed at almost all of my top choices and I ended up at my top choice. But I did not get interviews at some places, and my mentors are really surprised. And I think the only thing that they can point to is my step two score. So don't be discouraged if you're looking at a lot of these like self-reported databases like the Texas Star, and you're seeing that the median score for your program is at 260. You don't need that, but shoot on getting as well as possible. Try and get a 250 on your practice exam so that there's a cushion in case you drop lower. Like me, I got a 250 on my last practice test and got a 236 on the real thing. You never know what's going to happen the day of. But this is all about, like, the common theme here is position yourself for success. And then when the chips fall, just handle it as it comes. I think that's another lesson on talking to mentors. As soon as my step two score came out, the very first thing I did was hit up all my mentors and say, hey, this was not what I was expecting. This is not what I was projected to get. What do we think about this now? Should I pivot? And I had them say, no, stay the course. Like, the rest of your application is really strong.
Right.
So I think that's also a testament to having the people in your corner that you trust to be giving you that really sound advice as you're about to do this.
Absolutely. And that's the groundwork that we were talking about in the first question. Like, first and second year are super important for these kinds of things. You never know
Absolutely.
what's going to happen in the application cycle and who you're going to need to advocate on your behalf. And for me, networking and establishing relationships and connections have never failed me. And I understand that people are introverted and it can be extremely difficult for some people to get themselves out there, but I've never regretted forming relationships with people in surgery.
Not even once. One thing I want to say quickly, just to going back to like standing out, like I think what we're saying a lot that especially people applying to general surgery need to take away is that it's a very large applicant pool. It's about 1,000 people for categorical spots and about 1,000 people for prelim spots. So, and it's a very homogenous pool. I think one thing that you can do to stand out and really get to know people is face-to-face interactions. And one really, really good avenue for that is at meetings. And so if you can present, fantastic, but even if you can't get something accepted, still go to these big academic meetings because chances are that program faculty, program leadership, chiefs of divisions, chairs of departments are all at these meetings, and people remember you when they come across your application. They say, I remember meeting Justin at the American College of Surgeons Clinical Congress. I remember one of my chiefs told me about Justin from the Society of Black Academic Surgeons. That makes a big difference when it comes time to get interview invites. And then we can talk more later in the conversation about how to actually show up to those interviews and dominate, because you just need to get the foot in the door. How you get on the rank list is largely determined by how you do on your interview.
Nice, nice. Well, that is amazing advice, guys. Appreciate you guys. I think we hinted a little bit on letters and mentorship. So we talked about that a little bit, but maybe talk a little bit about how do you ask somebody to write your letters? For somebody who maybe hasn't had a lot of exposure early on, like who should they ask for a letter? Is it okay to get a letter from a not surgery mentor or department? How does that aspect of things work? Justin, you can start with that one.
Yeah, so I think I'll start with the last thing you said. Again, these are all my opinions. I have not vetted these with anybody, and this is not reflected in data, but I'm going to give you my opinion. My opinion is that if you're getting 4 letters, 4 surgeons need to write them. And ideally, it should be 4 people that know you really well. And that's hard to do, which is why I think it takes 4 years to really get to a position where you can get really strong letters of recommendation from multiple people. And when I say a really strong letter, I mean something that says that you as an applicant have what it takes to perform above your level at every stage. And so as a 4th year student, you can be trusted to do things that a PGY 1 or 2 is expected to do. As a PGY 1, you can be trusted to do things that a PGY 2 or 3 is expected to do. And not that you're in a position where you're forced to do these things, but the people that are advocating for you trust you enough to say that you learn well, you respond well to feedback, you can take initiative, and when things aren't right, you know how to escalate things appropriately. And those are things that unfortunately someone I don't think will comfortably say about you after a 2 to 4 week rotation. If that's the position that you find yourself in and you're a 3rd year thinking, okay, I just decided I want to do surgery, how do I get these strong letters of recommendation? My advice now, with how competitive things are moving, it's a really good idea to take a year to just develop those relationships, develop that research portfolio, develop the experiences that then people can say, okay, now I'm really comfortable writing you this really strong letter of recommendation. I think it's really, really difficult to get multiple strong letters in the span of a month, because I think like if you put yourself in the position of that letter has to basically say that I am comfortable vouching on my reputation as a practicing surgeon, that this person should join the club. If you're fair with yourself when you ask yourself, would you feel comfortable saying that about someone that you know for 2 weeks? I wouldn't. And so I think as early as you can, start developing those relationships and really focusing on getting strong letters.
Agree completely. And I do agree that all of your letters should be surgical. However, we do know that nothing is perfect in this life. So I will say, I will speak on some of the alternative methods. And the first method is having letters from other rotations where you've performed well and formed strong relationships. And this goes into another point, which is perform well and be your best self in all of your rotations. And look for someone to write you a letter in all of those rotations, right? Because, for example, you know, that person that you're working with knows that you don't want to be an internal medicine physician, but they see you as could be a good surgeon. Even if it's like, you're like, dang, I have 3 surgeon letters, but you're like, I remember I have this internal medicine letter from somebody who knew how interested I was in surgery and really did enjoy having me on this internal medicine service, right? Like it doesn't hold the weight of it is, I mean, I guess depending on who you talk to, it doesn't hold as much weight as a surgery letter. However, that person can vouch for all the other characteristics, right? They may not have observed you in the
I
OR,
agree.
but they observed you with patience, how your bedside manner is, how hard you work, how well you learn, right? How adaptable you are. All those other things that are qualities of a good surgeon, they can talk about, right? And then also I will say, in terms of alternative letter, other surgical specialties. So I had 3 surgery letters from general surgery subspecialties, and I had a 4th letter from a GYN oncologist. And so for people who don't know what GYN oncology is, it's all surgery. So you spend
Right.
half of your time in the OR and then you spend the other half of your time in the office with your post-op patients, with your oncology patients, with your consult patients. And, I was like, look, I tried really hard for a letter from my 3rd year rotation. I have researched with them. I worked really hard for them. But when it came time for a letter, everyone was dragging their feet. And you kind of, and that's a third point, don't force a letter. Like,
Absolutely.
I thought that I had it in the bag with at least 2. attendings for a letter. And when it came time for me to ask, I was getting the runaround. It was like I was hardly able to communicate with them all of a sudden. And I had to sit down and ask myself, Naomi, do you want a letter from somebody who is not eager and willing to write it? And the answer was no.
Yep.
And so I ended up with
Yep.
one less general surgery subspecialty letter, but I had a great relationship with this GYN oncologist, and she could talk about my skills in the OR. She could talk about all those like tactile things that you kind of really do want to hear, and then also those non-tactile things that you kind of want to hear as somebody who's applying to surgery as well. So I was a little upset, of course, by that fact, right? You think you work hard, you think you're expecting, and this and that. But if you position yourself for success in every rotation, if what you want doesn't come to fruition, you at least have a backup and you didn't like kind of just show up and, just skate by because you're not interested in that specialty. So, yeah, sorry, that was probably a long answer, but if the worst comes to worst,
No.
you have options.
I think it was fantastic. I wanted to add something really quickly. I think Dr. Watkins made a fantastic point. I think the first one is be really comfortable with the pivot. I think if we're still talking about away rotations, I can talk to some of the pivots that I had to make. But, she wanted to get a letter from all general surgery subspecialists. She was in a position where a letter from gyn-onc would make a lot more sense. And then going back, I think that ties directly into another point we made earlier. It all should tie into your narrative. And so if I'm the program director looking at her application, I'm not going to say, why is there this random letter from gyn-onc? It makes perfect sense in the context of an applicant that says that she really wants to do surgical oncology. At the end of the day, oncology is oncology, whether it's gyn-onc, whether it's thoracic, whether it's complex general surgical oncology. Cancer is cancer. And at this point, you're a medical student trying to get as much exposure to things as you can. So those are really two really, really important lessons there.
Yeah, and we can kind of get into away rotations a little bit. How did you guys decide do away rotations? Because some people would say don't do away rotations because that's just a high of an opportunity for you to mess up and for that program to and for some people it's say do away rotations. So what you guys take on that, and how many would you actually do, Naomi?
So I always chuckle a little bit when I hear people say don't do away rotations. Not because like I think one reason is like true or not, like I still don't know, but just as a DO student, we have to position ourselves to be in front of as many people as possible to prove ourselves, especially in surgery. So I don't believe that I ever had the option to not, right? So my perspective going into fourth year was to do as many as you can physically handle. And that's kind of a toxic way of behaving, but I truly feel like I got so many good experiences. I made so many connections and I got interviews at places that I wanted to get interviews at because I did away rotations. And, like, I think not to say that I should want to go to a place that has bias against DOs, but I do feel like being there, showing up as my best self, performing well, not only helped me with my application and with the interview season, but I also think it helped me develop incredible skills and incredible experiences, operative and non-operative, that I'll go into residency and be like, oh, I've seen this before. Oh, I like this. Oh, I've experienced this. And so far, I haven't seen any reason to not. Just like personal experience, I haven't seen any negative except the financial burden of doing away rotations. Like if you can afford it, I feel like you should do it. And it could just be my perspective, but I really feel like they are more helpful. They're more helpful than harmful.
What do you think, Justin?
I mean, I know you can't see me because my camera's off, but I'm just sitting here nodding my head emphatically yes, because my good sis is speaking the truth. I agree with all that 100%. The advice that I got from Einstein was don't do aways for general surgery. Similar to what you had said, it's an opportunity to shoot yourself in the foot, basically. I disagree with that wholeheartedly. I think that you need to be prepared for it. But, one of my mentors, Dr. Gabbett Woodard, she's a thoracic surgeon at Yale. We had a conversation beforehand that was essentially like, this is your opportunity to get number one on the rank list. Like you're there for a month to A, assess the program, but B, let the program assess you, and C, outside of who you are on paper, everybody's excellent on paper. How do you do in the day-to-day grind when you're functioning as an intern? And honestly, what people told me, it says reconnecting. Am I good? Or am I breaking up?
No, you're good. I can hear you.
Okay. All right. So what people had told me when I finally got to my first away rotation is that it's harder in a lot of ways to be a sub-I than it is to be an intern. Because you're constantly proving yourself every day for 30 days. So the way that I prepared for my away rotations, I did two. I'll talk about them a little bit after. I did 3 months at home. So I was planning on dual applying to general surgery and cardiothoracic surgery. So I did 1 month on acute care surgery with my mentor, who's the chief of ACS at Montefiore. I did 1 month on thoracic with my mentor, who's the chief of thoracic at Montefiore, and I did 1 month on cardiac. And those are my 3 months back to back. It was very difficult, but I think like Dr. Watkins said, this is your chance to, show what you're made of. And if you want, how bad do you want it? Are you willing to put yourself through something that's difficult for 4, 5, 6 months to end up on the other side? And so I did 3 months at home. I applied for 2 scholarships and I ended up doing my ways through scholarships, which I think also goes back to what she was saying. This is incredibly expensive. And I think as many ways that you can alleviate the financial stress of it, do that. But I also think these scholarships, and again, the caveat is that this might be going away with the current political climate we find ourselves in. If there are scholarships for URM students, take advantage of that at the programs that you really want to be at. So I did a rotation at Yale through Dr. Paris Butler. He's a plastic surgeon at Yale, but he also does a lot of amazing work in equity in surgery. And so he runs a visiting student elective scholarship specifically for URM students. So I rotated on the trauma and emergency general surgery through that, and that was an amazing experience. And then I also got a scholarship through the Association of Black CT Surgeons to go and do a month at the Brigham and Women's Hospital on the thoracic surgery service, and that was an amazing experience. And so I think that's the best way to evaluate programs, let programs see you, and ultimately decide, like, is this a place that I want to be? And I think scholarships are a great way to do that, especially because they give you the opportunity to formally or informally meet with all of the people that are making the decision about who they want in their program. And so if you're fortunate to do an away rotation, I would definitely capitalize on that by meeting with the program director, meeting with the chief of the service that you're rotating on, meeting with the chair of the department, and spending time with as many senior faculty as possible so that when people have their meetings in their closed rooms, people can say, we've interacted with this person in a real world environment. And these are all the reasons why we think that he would be great for the program. But you really need to approach it like this is your month to show them what you're made of.
Yeah, that's such a good advice. I think when sometimes I hear about, don't do it, I think sometimes it's more of like, what kind of personality do you have as well, right? Because some people,
Yeah,
sometimes it's just that they don't know how to interact well with other people, and so that might be some of the reasons. But I agree with you. I think it's a great way for you to get up there and show yourself who you are, because even for you, you're actually gonna see how these people are. You're gonna see the residents when they're super stressed. You're gonna see them when
right.
they're tired, and so you'll like, this is
Exactly.
what I'm gonna be dealing with when I match here. So I agree
Exactly.
with that. Um,
Exactly.
I think that Naomi disconnected probably for a little bit, but I'm sure she'll be back in. But I wanted to ask you about, how does one do well on general surgery away rotation? What are the tips that you have for somebody to go into a place and stand out and ace it so that they can actually have a higher chance of matching there?
I think the number one tip is be flexible. I think every institution runs their sub-Is a little bit differently, and there's always going to be nuance in how to stand out on that one specific program. But I think if it all goes back to be flexible, I think that's how you set yourself up for success. I think like a really concrete example of that is that like Montefiore, when I was doing my home sub-Is, the expectation was really to be in the OR. So you pre-round on your patients, you present to the chief resident on morning rounds, but then you spend the whole day in the OR. I did that when I got to Yale the first week. That's where I did my first away rotation. And at the end of the week, the intern was like, hey, like, where were you? And I had to learn that the expectation there was that, yes, see your patients, yes, go to the OR, but also there's the expectation that sub-Is are helping on the floor. And you're really functioning as a second intern on the team in terms of progressing things with patients, checking up on things, making sure the tasks are getting done. It was a steep learning curve because it's not what I'd been accustomed to, but it was a great exposure to what it's actually like to be an intern, putting in orders, checking on things, running to the OR to talk to the chief, to talk to the attending, running to see consults with the consult resident. That was a really good learning opportunity, but I had to be flexible and I had to be willing to kind of go with the flow. And I think that goes into my second piece of advice: be helpful. And I think what being helpful looks like is going to mean very different things for very different programs. But I think learn what needs to be done and then do that. So I think when I was at Yale, what being helpful looked like was, making sure things are progressing on the floor, updating the handoff, making sure things are ready for sign out at the end of the day. Like that's how I was helpful. When I would check in, make sure that when the room was ready, I would wheel the patient back and start prepping them and start positioning them and setting things up. That wasn't necessarily what being helpful looked like when I was at the Brigham, because it was just a different flow. So when I got to my Brigham away and I was on thoracic, I remember one of the things that was the most helpful, they have like the whiteboard in the room. And for every patient before they get into the room, like the HPI needs to be written out on that whiteboard. So like their past medical history, past surgical history, the operation that they're getting, the 10 major steps of the case, the morning labs, and the most recent imaging and pathology. So that was something that the junior resident had to do every case before the patient even got in the room. And so I made myself helpful and made sure that that was done. Basically, like as soon as the last case finished, as they were cleaning the room, I was writing on the board for the next patient so that nobody had to think about it on the team. And when the patient got there, everything was already set. So I think those are the two like overarching concepts: be flexible, be helpful. And then I think the third thing, and one of my mentors, Dr. James Stewart, who's a chief resident now at Yale, he made a big point of telling me this, like, yes, this is your opportunity to shine clinically, but it's also an opportunity to network for a month. And so I mentioned this earlier, but like, this is your opportunity to meet with all the movers and shakers that you have like 10, 15 minutes to interact with on the interview day. I think a lot of people don't know that, but like general surgery programs, everybody's going to have you meet with the program director and the chief, but a lot of these programs, those are 5 to 10 minute meetings. So while you're at that institution for a month, especially if that's your number one, meet with the program director, meet with the chair, meet with the chief of the service,
Yeah,
get
yeah.
that
I think
FaceTime and
Justin
make sure you're
probably
networking
covered.
with people.
I'm sorry, Justin. I keep calling
Yeah.
you Justin. Should I call you Dr.
Naomi, we were
Oliver?
just talking
I'm
about how
sorry.
can you
I'm like,
stand out and do
if
well
you're
in
okay.
your away
Um,
rotations. If you have any other tips.
okay.
No. Absolutely. Please call me Justin. Please call me Justin. But I do that. I do that for a really
Hmm.
particular reason. I make a point because one of my mentors, her name is Dr. Mara Antonoff. She's at MD Anderson. She does a lot of research on just like professional behavior. And I think that women, and especially women of color, don't get
That's awesome.
addressed
No, that's
properly by
awesome.
everybody.
Seriously,
And so
that's
I make a
wonderful,
habit,
and I
especially for
appreciate it.
women
I
of
really
color
do.
and
Thank you.
women surgeons, to always address them as doctor.
Yes, and
And I
I
think it
feel
just
like
sets a
Justin mentioned some
really
probably
good
all the points that
precedent.
I wanted to
But
make too.
please don't call
And
me Dr.
the last
Olivera.
thing that I wanted to say is like to have situational awareness. I think you can be like so eager, like, and you want to make a good impression and you want to be as helpful as possible. But sometimes reading the room and understanding when it is okay and not okay to do certain things goes a really long way. And for certain people, it comes naturally, right? Like you can flow with what's happening in the OR, you can flow with the team and what's happening on the floor, but other people might need to pay just a little bit more attention when they get overwhelmed or when they get nervous or in the moment. And so, like, you know, you may have read the case, like read the steps of the case, like a gazillion times, watched 10 million videos, and you're so knowledgeable, and you just want to show that off so bad when you get to the case, right? But if it's an intense case, if the surgeon is locked in, like yes, unfortunately, it might be a missed opportunity to show all the studying that you've done, but it's not the time to let them know that you've done the work, right? Like put it in your pocket, save it for later. There may not be another opportunity. There might be, right? But that's a part of the game. You have to learn for your own benefit first and foremost. And then secondly, if you have the chance to
Yep.
shine,
Yep.
you will, but it's better to just be a team player, to help when you can, and to be appropriate than to just let everyone know how hard you've worked and how smart you are and how intelligent you are, like, and so you want to match, you want to be a surgeon. And so sometimes don't let that overtake, your ability to flow well with the team.
If
That
I could
is,
add a couple concrete things that you reminded me of that I forgot. I
yeah.
think know your patients. And I think everybody says that, but they don't really get into what that means. Like you should, especially as a sub-I, if you're looking to impress people, for by the end of the rotation, You should know every primary patient on the list, be able to run the list with the team, know what needs to get done for each patient, know what's already been done, and know what they need to get out of the hospital. When it comes to knowing your patients for the OR, know their hospital course, know what the operation is that they're getting, know the major steps of the operation and the anatomy that's involved. Have questions. I think when you know what's considered quote unquote textbook, then have questions about why that particular surgeon chose to do things in a little bit different way. And to what Dr. Watkins had said, like, you need to hone your kindergarten skills. And so, like, I think if you need to ask questions, because I think that shows intellectual curiosity. One of my mentors, Dr. Stiles, he always says, I need you to take an intellectual academic interest in this. And I think that means, like, you should have questions, you should be asking things. But when it's intraoperative, there's always like a couple questions that I ask myself before I ask a question. The first one is the Google test. Should I already have known this? And is this something that I can Google? If the answer is yes, you can Google it, then you
Very good.
should probably do that. The second question is this like an appropriate time? And I think before you ask any question, look over at anesthesia, look at the vitals. If the vitals are not stable, this is not a good time to ask a question. Look at what's happening in the field. If there's
Yep.
blood in the
Yeah.
field, this is
And then
not a good time
also
to ask a
another
question.
point too, just kind of bouncing off of each
And I
other,
think if those are like all
taking
safe,
ownership of
then
your
start with,
patients.
can
Like
I
if
ask a
you go to
question?
the OR with that
And they'll say
patient,
yes or no.
that's your patient to follow
Um,
from like surgery to discharge. Like you should really be keeping up with them. You should be visiting them on your own. You should be providing updates if you can, because it's a privilege, right, to be in the OR and see this patient through their hospital course, right? And it shows that you're taking initiative to learn and to help this patient from their surgery onward, right? And so every day you should be checking on them. You should know what their vitals are for the day. You should know what the tasks are for that patient for the day because you were in the OR with them, right? So yeah, that was just a kind of to echo that point. Yes, yes.
Sorry, one more quick thing I'll add. I like this going back and forth. Never, never, ever, ever lie. And I think like everybody says that, but I think it starts as early as being a sub-I. Because, what we've kind of been talking about is if there's 10, 15, 20 primary patients on the list, it's hard to know the details for all of them. And you're going to get asked a question that you don't know the answer to. And in the moment when your heart is pounding in your ears and like you get hot in the face and you start to sweat, it's really easy to say, yes, I looked at this when you didn't. Never do that because you're going to get found out and immediately your credibility is ruined. And if you're a sub-I, it's ruined for the rest of the rotation and probably the rest of the application cycle. If you're an intern, it's ruined for the rest of your time at that program. And as hard as it is, like I'll give you a concrete example when I was on my way rotation at Yale, similar to what Dr. Watkins had mentioned, right? I'm in a case with one attending. The case goes well. The next day, I don't see that patient on morning rounds because he's in the ICU. The attending asked me about it while we're in the middle of the next operation the next day. And I'm like racking my brain. I'm like, I thought I did everything. I thought I saw the patients. What do I do? What do I do? And I said, I'm sorry, I don't know. And like it sucks in the moment, but I made sure the first thing I did when we took the other patient to PACU and did the handoff, the first thing I did was get on a computer, check everything that I
Hmm.
should have already. And I called that attending and I was like, hey, I'm really sorry I didn't know this before, but I looked at everything and here are the updates and I'm gonna go check on this patient in person after. And I think they respect that way more, that you have integrity and that you're honest when you didn't do something, but you check up on it, as opposed to is saying, this patient's great. They got extubated. They took their drains out
Agreed.
and the patient crashed that morning. All their drains are in. There's 2 new drains. There's a chest tube in. Like, you can't lie because it's going to get found out. So just tell the truth. Own your mistakes. It sucks in the moment, but people will respect you more for it.
I cannot agree more. Just from now I'm a chief resident perspective, one of the things that I look at when I work with new interns is that like you can train anybody. I mean, yeah, you have to be confident and all that, but like you can train anybody, but the hardest thing
Hmm.
to train is trust and knowing that somebody you can trust and they can do or they can present to you something that you can be like, okay, like that's a good presentation and I agree with the assessment, right? Is, for example, now I take, as a chief, you take call from home and the juniors at the hospital. They have to see the patient, they have to do all the things, and then they call you. They're like, "Hey, I saw the patient. These are the things that are going on." But if you are usually lying when I ask you things, like, "Oh, did you look at the labs?" You're like, yeah, I did look at the labs. What are they? I think they are normal, and then I'm looking at the computer, they're not normal. I can't trust you. I can't trust, but those are so important because, you know, and I feel like, especially as a minority, like sometimes, you are going into a place where maybe you're one or two, and, especially at the beginning, you want to like prove everything that you belong there. And sometimes you're like, you want to be right in every situation. If you don't know something, say you don't know, and you'll look it up, come back stronger, come back stronger. Lie. That's like the last thing you can do, as a medical student, it's terrible as an OA student, but even as a resident, just do not do that because if people can't trust you, then people are not willing to teach you. So that's such an important point. I cannot emphasize that even more. So you guys made really good points on that. I want to move on into, rank list. How do you guys go about ranking programs, and why did you, if you did match your number one, why was that place your number one? Justin, you can start.
Yeah, so I think let's go back to the beginning. General surgery now has 15 preference signals. And I guess for the junior people that have no idea what that means, like you can essentially flag a program. They can see that you are, this is for ERAS specifically, so you're about to apply. You can flag a program. That program can see that you are particularly interested as one of your 15. They can't see what other programs you signaled. And so even before you get to the application, you kind of have to decide what those top 15 are going to be. Because for general surgery, at this point, the expectation is you should not expect any interviews outside of those 15, but there's no guarantee that you're going to get an interview just because you signaled a program. And so the advice that I've got generally as I was about to apply is like, make sure that you have conversations with your mentors about your competitiveness. Again, the importance of having people that are going to be honest with you, and making sure that that 15 reflects programs that are some reaches. I don't like the idea of a safety because I think in general surgery, there are no safeties. Every program is incredibly difficult to match at, but have programs that your mentors tell you have a very strong chance at. Some programs that might be a reach for you, and some programs that are kind of in the middle, including your home program. So that should be your 15 going into the application process. I had like my top 5 that I was really interested in as I was applying. And like full disclosure, MGH was all the way at the bottom of those 15. I was like, I'm gonna signal because it's MGH and literally no other reason. And I think that attitude came out of the perception that I had of it. I thought it was going to be stuffy. I thought there weren't going to be any people of color. I thought that it wasn't an environment where I would feel supported as a black man just because, it's Harvard, it's Boston. I had the perception that it was a very racist city. I did my sub-I at the Brigham and Women's, and even though I loved the clinical exposure, I really didn't like living in Boston at that time. I thought it was really isolating, and I just like I wasn't a fan in general of Boston. And so for all those reasons, like MGH was barely on my radar, and I wasn't even going to Signal. And then in August, they do a Harvard affiliated residency URM showcase, and it's the opportunity for all of the programs that are affiliated, regardless of the specialty, to come and meet with URM applicants. And so my wife and I drove up from New York, and we came for that. And that was the first time that I met the program director at MGH. That's Dr. John Greer. And I met him, and I met a bunch of the residents here. And I was like, wait a second, there's a lot of black people and they're very happy. And so that was kind of the beginning of it. And I really I always tell people like Dr. Greer is my favorite program director in the country out of all the programs that I interviewed at. And he is a white man, but he understands the importance of cultivating diverse excellence, especially at a place that historically has not included that in its mission. And so that made a really strong impression on me. And then when I went to the Society of Black Academic Surgeons, and a month later in September, he was one of 2 program directors that I saw there that were like, they took time out of their day. They're not getting paid. They come here and they support their residents coming. There were also a ton of MGH residents there specifically to go here and to recruit excellent candidates from diverse backgrounds. And so that made another really strong impression on me. And then on the interview day, I just really liked how high their expectations were of us. You know, they kind of, every program is going to have its culture, and you're going to find out a lot about the culture as you interact with it on the interview trail. But I like that it was not a matter of, you know, you need to prove yourself. You need to like prove why you deserve to be here.
Right.
It's, we invited you to interview because we think that you are the top 100 students in the country. And so that's why we invited you. We're here to see if we're a good fit for each other, but you are all going to be fantastic no matter where you go. And I really, really appreciated that. I like that it was one of the most challenging interviews, and they do ask, you know, technical questions, they ask clinical questions, but I like that they expect their interns to know a thing or two about surgery coming in. And then also they have a really strong joint training
Awesome.
program with the cardiothoracic division. And so that was really, really attractive to me also. So for people that are not familiar with the free pathway, you match to general surgery, but then you apply internally to the CT fellowship. And so it was a really unique culture here, I thought, of people recruiting you for like with the intention of training you up to be a really strong candidate for their CT fellowship. And so that was really, really attractive to me. So all of those things, and then I think like all of that was really validated the week of match. I remember on match day, I saw who had matched to the program. 4 out of the 10 categorical residents are Black, right? 3 out of 4 of the people that are really interested in doing the internal CT program are Black men. And so I think it's also important to like, there's a lot of lip service that's done as programs try to recruit you, but I think you have to be able to parse out like what is true based on, like, the numbers don't lie. People can say all they want about diversity, but if they match year after year 4 white men, like that is not a program that really wants to diversify, and a program that's really serious about recruiting and supporting diverse excellence. But for all those reasons leading up to it, I was really
You're
certain that I
cooking.
was
You're
going to rank
cooking.
MGH1. And then since then, I think it's been incredibly validating, the experience that I've had before even like setting foot in the hospital in July. And I think one last thing, sorry, I know I've been talking for a really, really long time, but the mentorship element is super, super important. And so like, you want a program that, okay, they know like March 21st, they know that you're coming. You want a program where if you reach out to people for mentorship on Monday, they respond on Monday. And, you know, I had that experience here, and like I'm already involved in research with the thoracic division. I have a really strong mentor
That's amazing.
that like I'm already developing a relationship with.
Man, I don't know how
That's
to
what you
follow
want. You
that,
want a
but
program that's going to
I think
support you to be
it's
the best person
extremely.
that you can be, the best surgeon that
No,
you
it's
can be.
okay. I just
And
think
I'm
it's
confident
extremely
that I found that in my
validating, at
program.
least being in this seat as well, to know that I feel the same feelings about my program that you feel for yours. So I think that hopefully means that our expertise
I've talked
has
for like
some
10
value
minutes.
to
I'm
it.
so sorry.
But yeah, I mean, I completely agree with the way that you handled your signals. I did it in a similar fashion. I had
Yeah.
4 kind
Yeah.
of reach programs that I felt, I felt I met
Insane.
the level of competitiveness, but there probably was a cohort of applicants that were more competitive than myself. And then I had, I think, maybe 6 or 7 that fell within, like, I think I'm dead on in competitiveness. And then the, like, ones that I felt like I was like a shoe in for. I hate saying that because, like Justin mentioned, there's no guarantees. And if we're being quite honest, there were 2 of them I swore I would get an interview at, and I did. And then my reach ones, 3 out of 4, I got interviews at. So you literally never know. And like, it's all a blessing in disguise, obviously. But when it
Yep.
came to my rank
Yep.
list, I kind of want to speak from the perspective of a woman, because you have people say, like, you should not, you know, like, I just want to speak from the perspective of a woman, as in, your preferences are your preferences. And women in surgery are often up against this battle of, do I make my preferences because I prefer a place based off of the fact that they have mothers in the program, based on the fact that they support, any type of maternal leave, like, or I'm picking not necessarily the best quote unquote program, but I want to be close to my partner, right? All of those things women have to sometimes be like, wait, are these real preferences for me? They are real preferences. Yes, you're a surgeon. Yes, you're serious. Yes, you care about your career. But if those are your preferences, those are your preferences. And now is the time. Can you guys hear me?
No,
I think we lost it.
I know.
In the meantime, while she's coming back, I will co-sign something that she said that I think is really important.
Mm-hmm.
You are going to be surprised both ways.
Mm-hmm.
You're going to be promised interviews at places and then you'll never hear from them. And
Mm.
you'll never expect to get interviews and you will get interviews there. I think, like we were saying before, like the hardest part about the application process is getting the interview. Once you get an interview, you have the exact same footing as everybody else. And now it's your opportunity to showcase your talents, your expertise, your junior expertise, and why you think that you're a good fit for a program. But it's also an opportunity for you to evaluate a program similar to when you do an away rotation and figure out, is this a good fit for me? So like ask the tough questions. If you're
Mm-hmm.
interested in a fellowship, figure out like where people have matched, if they've matched, figure out what the diversity is look like, especially if you're an underrepresented minority. Get a sense of, I think the culture and the outcomes are the two most important things. I don't personally think like the actual day-to-day work is super important, and I wouldn't let that's not how I made my decision, because at the end of the day, this is general surgery. Every program in the country is pushing work hours hard. It's general surgery. You don't get to be a good surgeon in 5 years unless you are working hard and operating. So I think like it's different from some other specialties. Like I remember my best friend and roommate, he applied to internal medicine, and I think larger parts of his decision making process was, what is the schedule like, what's the call like, what are the research opportunities. I think the research opportunities are super important, especially if you're at an academic program, but the call schedule, the you know I personally don't think it's that important. I think you're going to work super hard no matter where you go. I will say something that was not important to me going in that I can appreciate a lot more now is how many places you're rotating at, especially as an intern and as a junior resident. I think that you have to decide what you want. I think personally that the argument that I've that has been made to me that I agree with now, I think being at a program where the interns don't go out is a great place to be, because now you're in a position where you get to know people really, really well. Dr. Charles,
Did
what's
I
up?
say? I think yours is tomorrow. It's all good, unless I'm tripping. Yeah, it's the 10th. No, you're fine. Yeah. Do you know Justin?
Virtually, virtually.
Oh yeah, because you guys are going to the same place.
My camera is off because it's freezing really bad, but it's nice to see you. Are you going to be there on Saturday? Awesome. All right, so I will see you then.
No, sorry that you came in. Oh man. No, you're completely fine. See you tomorrow. All right, bye. That's a good surprise.
That was funny. Yeah. Yeah,
Actually,
we've only talked on Instagram, so that's
oh,
funny.
nice, nice. So you guys are gonna be probably chilling and hanging out the whole residency.
Yeah, and so like I mentioned Saturday, there's like a informal URM mixer for all of the surgery residents in Mass General and Brigham. And so like that's like an intangible thing that you start to get an appreciation for as you're going through the interview process. Like what is the culture, especially around supporting and recruiting and retaining really diverse trainees, really diverse faculty.
Yeah, yeah. That's important, man. You need all the support you can. This is probably gonna be the hardest, toughest time of your life so far, I'm telling you. And so you need all the support that you can get. So,
Yeah.
um,
And one thing quickly that I remembered, like to go back to the away rotations, I think something that's super important is having, big brothers, big sisters in both the residents and the faculty,
mhm,
diverse people. Ideally, like for me, it was really important to have Black faculty and Black senior residents that I could feel really comfortable going to and asking the stupid questions, figuring out how to navigate situations that come up, because they are going to come up, and that's just not on your sub-I. That's for the rest of your career. Having
mhm.
people that you can trust to say like, "Hey, I don't know how to navigate this. Hey, what should I do? Hey, how would you handle this? That's really important. And so, like, on both of my away rotations, I had senior residents and junior faculty that were really, really instrumental in giving me advice and telling me how to navigate things on prepping me. And that's super, super important.
Nice. So last thing I wanted to ask you was, if you could go back and give yourself one piece of advice during the match process and, the whole process, what would that be?
I think, I think you have to, like, you don't want to have any regrets when this is all said and done.
Mm,
Think this is your one opportunity. Jaron, my roommate, and I, we would always say, like, while we were going through the application process, leave it all on the field, leave
mm,
it all on the court. Like, this is your big one. This is your playoffs. This is your World Cup. This is your Stanley Cup. And you want to do things in a way that when it's all said and done and you open your envelope on match day, like, you know that you did everything in your power to end up where you wanted to end up. And I think, like, I'm 98% of the way there. I think the 2%, obviously, I ended up at the program I wanted to. So I'm very, very happy about that. I don't have any regrets about that. I will say the one thing that I would advise people, like, there were programs that I didn't signal because I wasn't sure how competitive I would be. And I think that, like, in hindsight, I should have just shot that shot. There's no
mm,
way to know how things would have ended up. And, like, hindsight is always going to be 2020, but give yourself, like, this is your chance to bet on yourself. And if people are telling you to shoot for the stars, then shoot for the stars. And the last thing that I'll say advice wise
mm,
is that things are going to work out like exactly how they need to work out. You're going to end up exactly where you need to be. There are no mistakes. You know, God makes no mistakes and there are no coincidences. And so whether you end up at your number one program or your number 10 program or your number 20 program, or if you don't match and you have to soap to a prelim,
mm.
you are going to end up where you need to be. And you just have to have the mindset that you're going to have the resilience to make the best out of whatever situation you end up at. And it's all going to work out.
Nice. Naomi, I think you got cut off when we were
Yeah.
talking about match. You can go back and kind of continue with that.
Yeah, and I guess it could kind of tie into like if I could tell myself anything, but I was kind of just trying to say that your preferences are valid no matter what. Like I was trying to speak from the perspective of a woman because oftentimes we say, okay, like my desire to want children or start a family, shouldn't be high on my preference list when it comes to making my rank list. Like, no, if you know you want to have children at some point, but not a single person in your program is a mother, or they don't talk about their kids getting together, or they don't talk about having events and children being there, like, and you don't get the feeling that that's a supportive environment, but you're going to get great training, you have to sit down and evaluate and be like, what's really important to me? Right. And that's super, super, super important.
Mm,
And it's difficult to do when for years and years and years, you're worried about what other people want of you. Your 4th year, you really have to sit down and be like, "What do I want for me?" Right? And you can't worry about letting other people down based on your preferences. You can't worry about not being taken seriously as a surgeon if you prefer to be at a place that takes care of mothers and families. And, you cannot be intimidated by like certain things or scared to put yourself first, right? And I was on one of my sub-Is and one of the residents was like, "Yeah, I had a great opportunity to go to this awesome program. I really wanted to be there, but my husband is an immigrant and his only family member lives in New Jersey." She's like, "I couldn't take it if I moved him away from the only person that he has as his support system." And she put the program that she's at now at number 1, and she said, "I will never know where that place ranked me." But that was my preference. She was super, like, unapologetic about it because that's her life, that's her choice, right? And someone like me who's an empath, I made so many wonderful relationships and throughout my rotations, and I had people like, "We would love for you to be a resident here, like, please keep in contact," and, like, all this other things, and there's so many things going through your head when you're making your rank list, and you're like, "Oh my gosh, what if I let this person down, and that person down, and this mentor down, and this." It's like, it when it comes time to make your rank list, turn all of that off. Turn the volume down. What do I want? And
Yep.
I really feel
Yep.
like that's kind of how I ended up at like my number one choice because I was like, what do you want, Naomi? Like there's like places on my rank list, top hospital in New Jersey, they have the most money, gazillion dollars, right? Like, and then there's places who I felt like I can make a huge impact on the community, but they didn't have a lot of resources or money or funds or the research that I wanted. And if I went off of the feelings of other people or the feelings that or the expectations of that other people wanted of me, I wouldn't be happy. I wouldn't be as happy with where I am and what the end result of the match is. And so, like Justin said, everything will work out. You will end up where you're supposed to be, but even more so if you lean into your true desires. So,
And one last thing I'll say quickly is that when it sits down and it's, you know, March 10th or whatever date it ends up being, like, and you have to make your rank list, make it based on where you want to go. Where you think people are ranking you, it should be the last thing on your mind. Rank it where you want to go. And the match algorithm is designed to put you at the best place for you. And so people are worried that like, oh, if I don't rank a program that I think is going to rank me, I'll fall far down my list. The only way for you to do that is if each program that you rank doesn't rank you. And so when it comes down to it, rank the program that you want to be at and it will work out.
yep, agreed. And don't let
Very
anyone
agree
tell you
with that.
differently, even if it's a program.
Hell yeah.
Yeah, it's always on your favor. Well, Justin, Naomi, thank you so much for making the time again. And it was great talking to you guys. You guys get me. I mean, I couldn't give this advice, to be honest. When I was coming through, this wasn't a lot of the stuff that you guys are doing now, we didn't do. So thank you guys so for doing this. And, hopefully we encourage some people out there.
Absolutely.